In this video, we're going to talk about ACL tears. So ACL is the anterior cruciate ligament. A tear of the ACL is one of the most important traumatic knee injuries to recognize, particularly in athletes involved in pivoting sports such as football, netball, basketball, and skiing. The ACL is a key stabilizer of the knee, resisting anterior translation of the tibia on the femur and contributing to rotational stability. When torn, the knee may remain structurally aligned, but functionally unstable, especially during cutting, pivoting, or sudden deceleration. Let's look at the mechanism of injury of an ACL tear. Most ACL tears are non-contact injuries. A typical mechanism is a sudden deceleration, change of direction, or awkward landing with the knee relatively extended and collapsing into valgus and internal rotation. Patients often describe a pop, immediate pain, and rapid swelling from hemoarthrosis within the first few hours. Hemoarthrosis means blood, essentially, in the joint. Many are unable to continue playing and later report a sense of instability or the knee giving way, particularly with pivoting movements. Associated meniscal, chondral, or collateral ligamentous injuries are common and should be actively considered. A useful way to think about the ACL is that it is less important for straight line walking and more important for controlling rotational load. This explains why some patients can walk reasonably well after the acute injury, yet feel profoundly unstable when returning to sport. It also explains why persistent ACL deficiency can lead to repeated giving way episodes, secondary meniscal injury, and progressive cartilage damage over time. So, what are some clinical features? Well, key historical features for ACL tears include a non contact pivoting or landing injury, an audible or felt pop, immediate pain followed by rapid swelling of the knee, inability to continue playing the sport, later episodes of instability or giving way, especially during cutting or turning movements. On examination, the most useful bedside test is the Lockman's test, which is generally more sensitive than the anterior draw test in the acute setting. In the Lockman's test, the patient lies supine with the knee flexed to about 20 to 30 degrees, while the examiner stabilizes the femur with one hand and pulls the tibia forward with the other. Excessive anterior translation of the tibia, or a soft end point, compared with the other knee suggests an ACL tear. The pivot shift test is highly specific for rotational instability, but is often difficult to perform when the patient is guarding. Here, the patient lies supine, while the examiner lifts the leg, internally rotates the tibia, and applies a valgus stress to the knee as it is moved from extension into flexion. A positive test is felt as a sudden reduction or clunk of the tibia around 20 to 40 degrees of flexion, suggesting ACL insufficiency. Assessment should also include range of motion, assessing for effusion, collateral ligament instability, meniscal signs, neurovascular status, and examination for associated injuries. For investigations, plain radiographs are often normal, but are useful for acute trauma to exclude fractures or avulsion injury. MRI is the investigation of choice to confirm the ACL tear and identify associated meniscal, chondral, or other ligamentous injuries. However, an ACL tear remains fundamentally a clinical diagnosis supported by imaging, not an MRI diagnosis made in isolation. Initial management for an ACL tear focuses on settling the knee before definitive decisions are made. It's important to control the pain and swelling, restore full extension and near normal range of motion, re-establish quadriceps activation, begin physiotherapy early, and assess the patient's goals, activity level, and associated injuries. Not every ACL tear automatically requires surgery. Non-operative management may be appropriate for low-demand patients who do not experience functional instability and are willing to modify activities. However, ACL reconstruction is commonly considered in younger or highly active patients, those wishing to return to pivoting sports, patients with recurrent instability, and those with repairable associated meniscal injuries. An ACL reconstruction essentially replaces the torn ligament with a graft, rather than suturing the ligament ends together in the usual case. The aim is not simply to create a stable knee on examination, but to restore function, reduce instability episodes, and support safe return to higher demand activity. Timing is individualized, but surgery is usually delayed until acute swelling settles and range of motion, particularly extension, has been restored, because operating on a stiff, inflamed knee increases the risk of post-operative stiffness. Rehabilitation is central regardless of whether the patient is managing operatively or non-operatively. After reconstruction, rehabilitation is typically measured in months, not weeks, with progressive restoration of strength, neuromuscular control, hopping capacity, and sport-specific loading. Time alone is not enough to clear return to sport. Modern guidance supports a criteria-based approach, including strength testing, hop testing, movement quality, psychological readiness, and absence of instability, with many protocols extending rehabilitation to at least 9 months before unrestricted return to pivoting sport. So, in summary, ACL tear is not just an acute sporting injury. It is a knee stability problem with implications for meniscal health, cartilage preservation, and long-term athletic function. Early recognition, careful examination, appropriate imaging, and a structured rehabilitation pathway are more important than simply deciding whether the patient needs an operation. Thank you.